So, my name is Ray Rogers. I'm a professor at the University of Adelaide at the Robertson Research Institute, and I've got the job of being the MC or the chair for tonight. So the topic is peri-conception planning to protect pregnancy and infant health. And since mostly there's women here tonight, I guess you're all pretty interested in that side of things. So I wanted to illustrate just how important this topic is by asking for somebody in the audience who knows their mother's birth date. Can somebody tell me the date that their mother was born, please? Yes, there's a lady right in the middle here with blonde hair who put her hand up first. There's no prize, I've got to tell you. Sorry about that.
23rd of
37. Okay, so if you wind the clock back to about November 1936, that's when the egg was created that made you and gave you half of your DNA that you've been faithfully copying ever since. Because your mother was a fetus in your grandmother when she made the egg that she then used to create you. So all that time, I mean, I know it makes you sound older than you really are, but half of you have been around here since that time. And so it's quite important then that we actually know what happens to eggs and sperm and how to preserve them and how to make sure we don't damage them. So if you think about it, what your mother did, and even what your grandmother did when she was pregnant, could have affected you directly in your development. So this is a really important topic that we're discussing here tonight. So we've got 4 speakers, and there's a little flyer on the table that actually has all of the things I was going to read out about each speaker. But what I suggest you do, if you wanted to, at some stage, just go and Google these people. Each of them has a website, each of them has a stellar career with a lot of things to their names. They chair important commissions and societies around the world. They've published a lot. They do active research, active clinical activities as well. And we've got 4 of the best speakers you could probably ever get together into one room here tonight. So, I've just got to make sure we're doing everything correctly to this spreadsheet here. So our first speaker is Professor Claire Roberts, who you've probably seen on the radio and the TV in the last 48 hours. She's been doing her presentations non-stop. And her talk is, by way of introduction for Claire Roberts. Claire Roberts is a researcher at the Robertson Research Institute, and she's co-convener of Healthy Development Adelaide, which is one of the co-sponsors for tonight, as is the Robertson Research Institute. Her interest really is placental development, implantation, growth of the fetus, and the things that happen throughout gestation, and the effects on both the infant that's growing and on the mother. So her talk tonight is what women can do to optimise their health and that of their baby during pregnancy. Claire?
Thanks very much, Ray. Thank you for that lovely introduction. I hope I won't disappoint anybody. But I have, as Ray said, I have been talking a lot in the last couple of days, so hopefully I won't be hoarse. So Ray talked about the really big picture of development and the importance really of women's health across generations. I'm going to really focus on what women can do prior to pregnancy and what happens during pregnancy. So I'm going to focus on the 4 major complications of late pregnancy. They are preterm birth, which occurs before 37 weeks, so the baby's born sooner than it should be. Preeclampsia, where the mother's blood pressure goes up and her kidneys don't function well, so she excretes protein in her urine. Intrauterine growth restriction, which is when the baby doesn't grow to its genetic potential. And gestational diabetes. Now, together, these 4 complications affect 25% of first pregnancies. I think most women who become pregnant for the first time don't realise that actually things can go wrong quite often. Fortunately, although these complications can be life-threatening to the mother and the baby, most of the time they can be dealt with and treated very well. However, in developing countries, they can be extremely important. We have about 15 million babies die each year around the world, and about 500,000 women die as a consequence of something going wrong in pregnancy or during childbirth. So our group is focused a lot on developing screening tests that can predict which women are at risk, and particularly we want to do that early in pregnancy, so interventions to prevent these complications could be employed. And that would be useful because women who are at high risk could benefit from intensive monitoring as well as potential preventative treatments. But how common are these complications? I mentioned that 1 in 4 get one of those 4 complications, but this is data from the South Australian Perinatal Statistics Collection over a 30-year period from 1981 to 2011, and this is on preterm birth. So during this period, if you see here, these are the gestational age categories. So around about 5 or 6% of babies are born preterm in South Australia over that 30-year period. Most of them, about 3/4 of the preterm babies, are born late preterm, so between 34 and 36 weeks. The babies who are a real worry are these about less than 0.5% of babies who are born between 25 and 29 weeks, and they really are at risk of dying and being seriously ill. But even these late preterm babies can have lifelong consequences for their health. What about preeclampsia? Well, unfortunately, the State Perinatal Statistics Collection only collects data on pregnancy-induced hypertensive disorders, which includes preeclampsia, but also gestational hypertension, where the mother's kidneys and other organs are not involved. But you can see over this 30-year period, and this is well over 500,000 births over that period, that the rate of pregnancy-induced hypertension oscillates between 7 and 9%. And it does look like there's a bit of a trend down, but I think that is actually a bit deceiving. And then gestational diabetes, this is data for a 25-year period in South Australia. You can see that worryingly, in 1987, we had about 1.2% of pregnant women develop gestational diabetes, and you can see over time it has just gone up and up. And that really is in keeping with the BMI of pregnant women in South Australia. So BMI is a big issue. Women who have bigger BMIs, particularly obese women, are much more likely to get gestational diabetes, but also preeclampsia. And intrauterine growth restriction, which I mentioned, occurs in about 5% of pregnancies. Now, some people will argue with that, they'll say it's 6% or it's 3%, but we work on 5%. Small for gestational age is by definition the smallest 10% of babies. So we've been working a lot on identifying maternal risk factors for adverse outcomes, and those in red here are things that we can't do too much about. Obviously our family history, our ethnicity and our genetics are pretty well set before we are born. Fetal sex is interesting, so that the sex of your baby can affect your health in pregnancy. But fortunately, a lot of these things that we've shown are associated with pregnancy complications are highly modifiable, and it's the modifiable things that I'd like to talk about. And why do I want to do that? Because our genetics, so the baby and the placenta's genetics are a combination of that of the father and the mother, and genetics do strongly influence how well the placenta functions and how the fetus grows. But also these environmental factors that include micronutrients, maternal diet, obesity, which I've mentioned, stress, the use of various legal and illegal drugs, socioeconomic status, all of these things interact with our genome and affect gene expression, and they affect how the placenta functions, but also how the mother adapts to being pregnant. And together, these all affect our epigenome, which you may have heard a bit about. Our group's doing quite a lot of work on epigenetic state in pregnancy in both maternal tissues and in the placenta. But I won't have time tonight to talk about that in detail. But what about BMI? I've been involved in a big study called SCOPE, which is Screening for Pregnancy Endpoints. We had 5,628 women recruited here in Adelaide at the Lyell McEwen Hospital, but also in Auckland in New Zealand, 3 centres in the UK and in one centre in Cork in Ireland. And you can see here I have the different pregnancy outcomes across the x-axis here. So these are non-cases, that is women who had uncomplicated pregnancies. Here's preeclampsia, gestational hypertension, gestational diabetes, small for gestational age, and spontaneous preterm birth. So this weight range here is a normal BMI. So we have BMI here on the y-axis. And you can see that all these pregnancy outcome groups, the average weight in these outcome groups is in the overweight range, and indeed many of our women actually were in the obese range. So, for example, at the Lyell McEwen Hospital, over 55% of our pregnant women were either overweight or obese at the beginning of pregnancy, which is a great worry, considering they do significantly contribute to all of these complications of pregnancy. So we've been developing a tiered prediction approach to identify women who are at risk, and I haven't got time to go into those either, but what our models have done, and that's what I've been talking about in the news the last couple of days, they pointed to some very modifiable risk factors. So one of them is red cell folate status, so how much folate you have in your red blood cells. Now, red blood cell folate is a great measure of your folate status because red cells live for about 3 months. So they give an indication of your folate status, so how much folic acid you had in your diet, over at least a 3-month period. So just here we can see, this is actually a study not in SCOPE, but it was performed in women at the Lyell McEwen Hospital. Here you can see anything to the right, so these are folate status high, insufficient or deficient compared to normal, and here's the value for normal folate status. And you can see here that women who were deficient in red cell folate, and this was measured at 12 weeks gestation, were more likely to deliver their babies preterm. And those women who were deficient, but even those women who had insufficient levels of folate in their red cells, were also at risk of delivering their babies, babies who were small for gestational age. So we know that the red cell folate from this data is associated, particularly if it's deficient, with a lower birth weight. But also, what does folic acid supplementation do to a woman's red cell folate? So this is data from women who either supplemented with folic acid or who did not supplement. And you can see it's a no-brainer. Their red blood cell folate status goes up when they supplement with folic acid. But also folic acid supplementation in these women, you can see here, was associated with birth weight, an increased birth weight, but also with a longer gestational age. So the mother's red cell folate status and her use of folic acid supplementation both increased her baby's birth weight and gestational age. So we know that folic acid is recommended for women to prevent neural tube defects, but this data and data of others suggests that also it can be important in preventing important complications of pregnancy. We're also doing some work on vitamin D in pregnant women. We also have some animal models on that, and here's some data from Alison Leviton, who's in the audience, where we've measured 25-hydroxy vitamin D in maternal blood at 15 weeks gestation, and this is in SCOPE women from Adelaide and Auckland, nearly 3,000 women. So this is the distribution of the concentration of vitamin D in these women's blood, and this is the number of women in each of these. And you can see it follows what you'd expect, a norm curve, but worryingly there are a significant number of women who are deficient in vitamin D and a significant number who are insufficient in vitamin D. But vitamin D, this is not the only story. So women who are deficient in vitamin D have been shown in many other studies to be more at risk of pregnancy complications. That's not always replicated in every study. But also there is some evidence to show that even women at this high end may also be at elevated risk of preeclampsia. So I certainly wouldn't be recommending women to go and take mega doses of vitamin D, but it is something to think about. And particularly it interacts with a number of other things. Obviously it will interact with our genome, as I've suggested before, but also this is the data from the same nearly 3,000 women, and you can see down here on the x-axis are the BMI categories, and you can see women who are of normal weight or even in the overweight range, they have a very similar concentration of vitamin D in their blood. But women who are obese and also women who are underweight have lower vitamin D levels than those women who are normal weight. So it's important to think about micronutrient status as interacting with other factors in the mother. So what can women do to modify their risk for pregnancy complications? You obviously can't change your genes, but we have not identified any genes that unequivocally predict a pregnancy complication. So we can normalise our weight before pregnancy. Also, I haven't mentioned normalising the weight of your partner. We've shown that obese men are more likely to father a small for gestational age baby. Women could also eat a good quality diet. There is quite a significant amount of evidence suggesting that a good quality diet improves outcomes. Women should supplement with recommended micronutrients, have regular exercise, not totally over the top vigorous exercise, but there is a significant evidence to associate regular moderate exercise with good outcomes. And women should also avoid smoking, using alcohol and other illicit drugs. There is a significant amount of evidence about the use of these sorts of drugs and adverse pregnancy outcomes. And ideally, women should start all of this planning before they become pregnant. Because we have shown, and others have shown, that even pre-pregnancy fruit and vegetable consumption is protective against a number of these pregnancy complications. I'd just like to thank everybody in my group, without whom I couldn't be reporting this nor giving any recommendations. Thank you very much.
Thank you very much, Claire. Thank you. Our next speaker is Professor Rebecca Robker. She's from the Robinson Research Institute. And I kept looking for you a minute ago and I'm thinking, where's she gone? She's not here, but she is here. So can you get your talk uploaded? So Becky's really interested in, she's really interested in the events of ovulation, the effects of diet, nutrition on the oocyte and what that means for the offspring from there. She's a basic scientist at the Robinson, and I'm going to just shut up and let you start talking. Thank you.
Thanks, Ray. Thank you very much for the opportunity to speak. I'm going to share with you guys some of the latest science behind what we know about the relationships between fat and fertility, specifically the effects of body fat on the egg, which is shown here. But first, these icons illustrate something that's been known for ages, and that is that female body fat is essential for fertility, and this is nature's way of ensuring that pregnancies can be carried to term. And so these are from around the globe, and they illustrate that even ancient cultures knew that when food is plentiful and women are curvy, babies are going to come. We know a bit more about that now, and a large comprehensive study in the 70s of thousands upon thousands of teenage girls, it was published in Science, and they found that girls, irrespective of their height or age, they basically start cycling at around 48 kilos. And we're also familiar with the concept that elite athletes who have very little body fat will also stop cycling. But strangely, on the other end of the spectrum, women with high BMI and big women also have impaired fertility. And it's much less clear when exactly this becomes a problem. But definitely it's occurring when excess body fat transitions into a state of metabolic disease, and when there's things like insulin resistance and hyperlipidemia in the blood concurrently with just excess body fat. So obese women, unfortunately, are more likely to have altered cycle lengths and they take longer to become pregnant even when they appear to be cycling normally. And also, they also have an increased rate of very early miscarriages. And particularly these first two things indicate that there might be a problem with ovulation, or their ability to release an egg from the surface of the ovary so that it's captured by the oviduct and ready for fertilization. So, in case you don't think about the ovary every day, like I do, I was going to tell you some ovary basics. And that is that hormones from the brain act on the ovary on these structures called follicles, and the egg is in yellow in the middle. And these follicles grow to a large size, and it's surrounded by fluid and these cumulus cells. And when the ovulatory luteinizing hormone surge comes, this ball of little cumulus cells really goes ballistic. And what happens to this little tiny ball of cells, you can see the egg is in the middle, is that all those cumulus cells around it, they aren't proliferating, they're simply secreting a very, very viscous, sticky matrix of proteins. And we don't know why, but this protein production is absolutely essential for that egg to somehow get out of the surface of the ovary so that it can be fertilized. So we wanted to know whether this process was disrupted in obese women, and so we used an obese mouse model, and you can see that our mice that overeat get much fatter than their sisters that are much leaner. And we can record the cycles of the mice, and here they are doing their ovarian cycle, which in them occurs over 4 days. But as they got fatter, their cycles became more irregular, just like happens in obese women. So this illustrates that there is a problem with hormone secretion from the brain as obesity onset occurs, that it's not normally triggering that cyclicity that should be happening with those brain hormones. So we've done other experiments where we give the mice hormones to mimic those from the brain, but what we find is that when we look at their ovaries is that even when they're given normal doses of the hormones from the brain, in the obese mice, their ovaries still are not releasing the egg. It's staying trapped inside those large follicles in those mice. And we've looked at their ability to secrete those proteins that have to surround the egg. And here in the normal mouse, there's its egg in the center and all those cumulus cells. And that red staining is this pentraxin 3 protein that's essential that those cumulus cells have to make in order to get out of the ovary. And in the obese oocyte complexes, there's none of that red protein around their cumulus cells and around their egg. And so we think this is a big problem and why they don't ovulate. So this is just another photo of those matrix proteins that surround the egg, and the green one is one called Versican, and red is one called ADAMTS1, and they're both of these sticky proteins are essential for that egg to even get out. We don't exactly understand why, but we know that they are. But what we have found is that when as obesity happens, these cells that surround the egg, they have lost their capacity to make those proteins. And it's a complicated cellular process, but they can no longer secrete those proteins that enable the egg to get out. But we also wanted to know, within obesity, what happens to the actual egg itself. And so for this, I'll show you the embryo basics. And this is a human embryo developing in the first days after it's been fertilized in vitro. And so you can see that after it's ovulated, it gets fertilized, and it goes through these various stages called morula. It compacts, and then it forms this blastocyst embryo that's just like this one here. And it's when this blastocyst embryo has formed, it's only when it's at this stage that it can be transferred back to the uterus and it can successfully implant, because the uterus is coordinated with the ovary in becoming receptive at exactly that time. So what that shows you, because all of this can happen in vitro in isolation, after just fertilizing this egg, it illustrates that the egg itself is basically a big container of information. And it holds, so this is another mouse egg, and it contains all of the constituents that are able to make that first stage of embryo. So obviously it contains the DNA, which encodes the genetic information of the next individual. But also the egg contains a lot of lipid droplets that are here stained green, and this is thought to be essential nutrition for that egg to make an embryo. And also stained in red are organelles called mitochondria, and the egg is full of mitochondria. And you might also be aware that the mitochondria in the egg, after it's fertilized, have to rapidly proliferate because those mitochondria in the egg have to proliferate and repopulate every cell of that embryo and indeed of that offspring. And so all of the mitochondria, which are responsible for energy production, that are in your cells came from the mitochondria of your mother's egg. So we wanted to look at whether some of these important information transmitters were disrupted with obesity. And one of the first things we did was look at lipid content. And again, these are mouse studies where we found that when we fed mice a high-fat diet, their eggs became full of fat compared to these mice on a control diet. And when we did IVF on these eggs that were full of fat had slower embryo development than the lean mouse eggs did. So we also looked at the mitochondria using a stain that measures their activity in red, and you can see that in the eggs from the lean mice, they have lots of healthy active mitochondria, and there's many less red or active mitochondria in the obese egg. And this indicates that the mitochondria in that egg might be damaged. And indeed, when we did IVF on these two different types of eggs, here's in the egg, you could see that the mitochondrial content was similar when they were eggs, but in the lean, as the lean eggs grew into embryos, they increased their amount of mitochondria, which we measured as their mitochondrial DNA. But the eggs of the obese mice didn't do that. So we ended up with embryos where the ones that were derived from obese mothers already had less mitochondria as embryos. We then took these two different kinds of embryos and we transplanted them into other mice, none of which were obese. They were all lean. And we found that this difference in the offspring persisted. So when we looked at the livers of the offspring, those that had been conceived from obese eggs still had less mitochondria in their livers, even though they were subjected to the exact same IVF and the exact same gestation in utero as the others. And we also found that these offspring were heavier. And so we think that these alterations in the mitochondria of the egg are actually leading to a propensity for obesity or insulin resistance in offspring. And this concept that an obese egg can lead to an obese offspring has been demonstrated in other studies, also in mice and sheep, where they found that the weight of the mother sheep at the time she got pregnant was related to the amount of fat that her daughter lamb had. And similar studies have been done in mice. And there's evidence that this occurs in people as well. Maternal BMI prior to pregnancy is associated with a child's BMI at 7 and 14. And there's even publications showing that children of obese women are more likely to be obese by the time they're 2 years old. And there's a couple of really interesting studies showing that a child that was conceived after very dramatic maternal weight loss, and these was all gastric banding in this case, that those children that were conceived years after the mother had gastric banding and was thin were not obese compared to their siblings who were prior. So these effects of obese mothers on offspring, we have found in some of our mouse studies are actually reversible. We have found that an insulin sensitizer that's commonly used in type 2 diabetes called rosiglitazone, that if we give this to our obese mother mice for only 4 days prior to conception, that it improves their ovulation and their embryo development. And there's another drug also in clinical trials for diabetes called BGP-15, which activates mitochondria. And we found that this also, with just 4 days of treatment to the obese mothers, that it restored the obese mice's ovulation, their embryo development, and those defects that we saw in the liver and the kidney and the heart and their weight. So these studies are really important because they show us exactly what cellular pathways are the problem in terms of insulin signaling being a problem and mitochondria being a problem. But really, why should we need the drugs? And really, one of the forefathers of modern medicine said that food should be our medicine and medicine should be our food. And there's a huge amount, increasing interest, I believe, in fertility diets. And I think there's, a genuine passion for people wanting to have the best nutrition they have to conceive and also for the health of their baby. But do these types of diets really work? There's plenty of them to choose from. So again, to test this, you can go back to the studies in mice. And there was a recent paper where mice were fed 25 different diets that were isocaloric. And they do these funky geometric framework modeling of the results where they can look at the amount of protein, fat, and carbohydrate in 3 dimensions on this graph. And basically what it shows, I'll just tell you, is that in the mice that had a relatively low protein diet, those were the female mice that were still ovulating out to 1 year of age. And when they looked at their ovaries, again, when the ones that had been eating high carbs or relatively low protein their whole lives were still ovulating because the eggs are gone. The ones on high fat, their eggs were still in the ovary. So this illustrates the concept that it's not just amount of calories that affects fertility, but that specific macronutrients do as well. So my lab is also interested in this concept and looking at the effects of micronutrients on the egg quality. And especially we want to see if we can reverse the effects of obesity by including specific nutrients within that high-fat diet. And what we found in some of our studies is that when you look at the optimal embryo development, you can see that the mice that were fed the high-fat diet have slower embryo development, but if we include a specific nutraceutical that's already on the market for human consumption, you can get better embryo development from these mice. And when you look at these embryos, they are at these stages of blastocyst and hatching blastocyst that I showed you that are the really well-developed stages of embryos. So again, this just illustrates the concept that specific food components can really affect fertility, both ovulation and egg quality. So what about exercise? Can it improve fertility? There's a couple of recent studies that show that exercise can increase a woman's IVF success rates. When they looked at just all women, they found that women that were moderately exercising compared to not exercising at all had improved pregnancy and live birth rates in their IVF experience. And this is not a lot of exercise. This was like 20 minutes a couple of times a week of activity or moderate exercise. And another study focused specifically on obese women that either did some exercise versus no exercise. And this is not a lot of exercise. It was just their normal activity levels that were surveyed by questionnaire. And they found that those who exercised had 3 times better chance of becoming pregnant by IVF and almost a 4 times greater chance of live birth than women who weren't exercising at all or weren't active at all. So what about the health of the baby? Can that be affected by exercise as well as those fertility parameters? And again, to get that kind of data, we can use animal studies. And this is a recent paper that came out in mice because this is a huge interest area in the field right now, looking at exercise biology. And they had mice that were in just normal cages, and then they had mice that had access to exercise prior to pregnancy only. And again, they weren't forcing them on running wheels. They basically gave them, one of these things with tunnels and basically opportunity for play is what they called it. And they then, in those mice, as soon as they conceived, they transferred their embryos to standard mice that had not had the exercise. And even so, the offspring of the embryos of the mothers that had exercised had less, shown in black, they had less fat in some of their fat depots. These offspring had lower blood lipids, also shown in black, and in their fat, they had less cholesterol and triglyceride in their livers. So this illustrates the concept that even exercise prior to pregnancy can actually influence that egg in ways that have lasting consequences on an embryo. And just one last study I'll show you that's come out recently, again in mice. And in this strain of mice, as the mother mouse gets older, her offspring have a propensity for a specific heart valve defect, and this mimics a clinical condition. But you can see here that in just your standard sedentary mice, the mothers that are old, their offspring have much greater chance of having this heart valve defect than the younger mothers. But when they exercised the older mothers prior to pregnancy, their offspring no longer had this propensity to have this heart valve defect. They were having it at only the normal rate of occurrence. So I think this is really, and they didn't even have to exercise for very long. They had a late onset exercise group that was only for about 3 months. And these mice were about a year of age when they were conceiving. So I think this data is really profound, showing that there are concrete effects that exercise can have on fertility. So I just want to leave you with this concept that this ovarian follicle, in case you've never thought of it before, is a really important biological structure, and it holds the continuity of life in its mystique because these cells around it nurture it, and they stockpile it with the things it needs to form an embryo, and then they also control it being released at exactly the right time that it needs to be released for pregnancy to happen. But what I've tried to show you with some of the science studies is that, it communicates this all about the maternal body to that egg, and that this dialogue commences long before conception, and that this egg is soaking up that information from the moment it's formed. And it's sensitive to both nutrition and exercise. Thanks.
So our next speaker is Dr. Susan Evans, who's a gynaecologist, a laparoscopic surgeon and a specialist in pain matters management. She's an author of a number of books, including one called Endometriosis and Pelvic Pain, which is the title of her talk tonight.
Thanks so much for inviting me. I feel like a little bit of a ring-in because this is not about pregnancy, but I do think that in that search for fertility, so often we lose track of the health and well-being of the mother, and that her own needs are often put last when it comes to the pregnancy. And if she's got pain, it's often said, well, you can't do anything, you're trying to get pregnant. And I'm hoping to explain a lot of things, how you can actually care for her and help improve her quality of life, which I'm sure must be important for the pregnancy and the family as well. So, now, I've got a few photos and I've got a couple of videos, so if you're somebody who doesn't like looking at things, just sort of look away or something. Now, and so I'm hoping you can see, all right? Now, just looking at what a pelvis looks like. Oh, I don't know where the zoom came from, but anyway. So, the big pink thing in the middle is the uterus. This is looking down into someone's pelvis. Just imagine you're looking down towards their feet. And there's the white ovary here, and the fallopian tube, and a white ovary and fallopian tube. And you can see some of those follicles, these little pearly things here. Now, this is a lovely pelvis. And it's covered by a beautiful slippery thin skin called peritoneum. And if we just look here, which I think should run okay, I'm just going to show you some pictures of endometriosis so you can see that it has many different appearances. Oh, that's not what I want. Sorry, we'll just get back to here. If I can I just have to get to the arrow, really. There it is, I think. There we go. Now, this is another pelvis. It's a little bit bright in here, but I'm hoping you'll see. And down here, along the uterus, Do you see this abnormality here? There's this sort of fleshy area, there's a dark area, but not showing quite so well. There's a whole lot of clear little bubbles that are endometriosis as well, but don't actually look so abnormal. So that's sort of some areas you might see. There's lots of different appearances. If we lift up this ovary, on the side, there's this sort of red, slightly inflamed vascular area. If we look under the left ovary, and she's got beautiful ovaries, always good for having babies, and she's got sort of scarred, mix of white, mix of dark, lots of different appearances of endometriosis. Now, none of this would show on an ultrasound. So if she's got a normal ultrasound, it doesn't put me off at all. So she's got some areas of endometriosis, but nice ovaries. If you have a look out the side, there's another area of endometriosis on the abdominal wall. You can see it's a bit inflamed around it, that's so common, and this is her beautiful appendix, just nice and normal. Okay. Now, all of the endometriosis I showed you, you wouldn't see on an ultrasound scan, but here's something that you would. So this is an endometrioma, and that means a cyst of endometriosis in the ovary. And so that's her white ovary there, don't worry about the bit of blood, and this is an endometrioma. And they're called chocolate cysts because if you open them up, out comes the stuff that looks like ice magic. And so it's a cyst here, and that you would see on an ultrasound. But this is only a few % of the ultrasound of women with endometriosis will have anything to see. Now, when you think about endometriosis and when women think about it, we're all very much in this concept that if there's pain, there should be something to see, and the amount that you see should correlate with her pain. Well, I've got two patients here. One of them is on the left, and she's got a bit of endometriosis there, a bit over there, whereas this woman, unfortunately, has a really dreadful pelvis. She's got her ovary enlarged by 2 big lumps of endometriosis, both ovaries affected, and you see how the bowel is just stuck to everything? There's no room here. This is very severe endometriosis. But who has more pain? You can't tell. You've got no way of telling by looking at that who has more pain. Actually, this person had lots of pain. This person came along and said she never really had pain, but she wasn't getting pregnant. So you can't tell. Pain does not correlate with the degree of endometriosis. Now, it does correlate better with fertility, but it doesn't correlate with pain. So, common pain misconceptions, that if there's pain, there should be something to see, and if you cut it out, her pain should go away. Well, I think that's a bit unreasonable. If you have a headache, we don't expect to see lesions in your brain. And, people have worked out a long time ago that people with back pain don't always have something you could see on scans. So there's no good correlation between the amount of endo and the amount of pain. The other thing is that if you actually find something at a laparoscopy, then that was the cause of the pain. Well, not necessarily at all. There's loads of pains you can't see. It may or may not be related to her pain, and that's where you have to look at her clinical picture and a whole lot of other things to work out whether you believe that what you found is actually the cause of her pain. So, I see this sort of person, you can sit on the edge, every single day, all day at my practice. She might be 25, she might be 35, she might be 15. I had one 13 a few weeks ago. That's unusual, but anyway, she could be any age that has periods. She might have had those painful periods since her period started or soon afterwards. She's got a whole mix of things. She's got an irritable bowel, she's got food intolerance, painful sex, overactive bladder. She's also got maybe pain on movement, stabbing pains, headaches, fatigue, low mood, anxiety, poor sleep, nausea, sweaty, dizzy. So, this is really common. It's called persistent pelvic pain. And does anyone really believe that those lesions in the pelvis caused all of that? There's actually so much more to being someone with endometriosis than just lesions in the pelvis. So, this is a bit more of a visual of what her life's like every day. She's got the bloating, the tummy pain, the headaches, the stabbing pains, sex no good, bladder no good, sharp pain, she's miserable, she's got that black dog of depression, and she might have some burning pain. She's confused, the people looking after her are confused, and it's all just seeming too difficult. So, I always like to think of persistent pelvic pain in the context of what it shares with other types of pain. So, like any long-term pain, whether this is your husband's bad back, your mother's arthritis, your persistent migraine, whatever, there's usually that the pain started somewhere. Then you get often some pain and tenderness from the muscles that are nearby or relevant to that area. Then over time, the nerve pathways change. Nothing to see, but the whole picture gets more complicated. And then with time, there'll be all that impact on her life that having long-term pain has caused. And once again, I think we should think of it in the context of other pains. If someone has a back injury, they might have something wrong with their back, but often they will tell you that the muscle spasms were their worst pain. And if their pain doesn't settle down and they still have pain after 3 to 6 months, well, they do have a persistent pain condition and they've got changes to nerve pathways. And over time, they might not have been able to work. It may have affected their employment, their finances. They might not be able to have sex. They might all manner of things. So do you see how there are a lot of similarities with other types of persistent pain? There's differences too. So what makes it different for women? Well, they've got period pain and endometriosis that happens so young as an early stimulator of pain. That man who had an injury at work, he might be 40 years old. He developed his life being fairly healthy and yet might have developed something earlier. She might have had pain since she was 12 years old. There's estrogen, which is more and more recognised as a nerve sensitizer, an aggravator of pain pathways. And there's that cyclical pain. So every month she has another episode of pain, just winding the whole thing up. And there's the social stigma of all these troubles in those awkward teen years, which I don't know that many of us look back on with pleasure. So, just looking at how you might approach it, the pain starts somewhere. We're talking about endometriosis, so that's one way of starting. But it could have started in her bladder with a painful bladder. It could have started with bowel pain. It could have been recurrent thrush infections. It could have been a pelvic infection with something like chlamydia, although I think other things are more common these days. That's a possibility. Could have been vulval pain. And remember that when one of these organs gets upset, they're all going to talk to each other. So, when the period's bad, the bowel might be bad, the bladder might be bad, everything goes bad. So there's that cross-talk between organs. Pelvic muscles, this is by far the most neglected cause of pelvic pain that I see all the time. You can't see it on scans, you can't do blood tests, you can't see it at laparoscopy, and the muscles that cramp are on the inside. So often it is completely missed. And so you can have pain from the pelvic floor where all of that's quite rigid and tight. Pain with sex. They don't like smears, they don't like using tampons, they don't like vaginal examinations because they're painful. They're having to go past painful muscles. Pain with movement or ache. Well, a lot of women will come in and say, I got these really bad pains and I couldn't move. Well, the uterus doesn't care what position you're in. I don't think endometriosis lesions do either, to be truthful, but muscles care. So there'll often be a movement aspect to her pain. Stabbing pains. Stabbing pains that can come at any time, might be worse with periods, but can come at any time. The sort of woman that any gynaecologist sees a lot of, who will get up from her chair in the waiting room, come in slowly, looking like she's old, talk about what she often calls her ovary pain, not usually the ovary I don't find, stabbing pains on the side, wants to bend forward, says, I always curl up in the fetal position, my heat pack helps a bit, it's really, really bad, it comes on suddenly. Well, once again, I think if we think logically, it's hard to imagine how a lesion in the pelvis causes those symptoms just by itself. They can have difficulty emptying their bladder passing urine, and they often have a pain in their lower back. They might have a tender lower back, they might have tenderness across over gluteus medius. They say, I go for a massage every week and they tell me I've got this stiff back. And that's true, they do, but the problem's on the inside. The other muscles that most people haven't ever heard of is one called obturator internus. These are the ones on the inside of the hip. And these ones actually tip around to be attached to the leg. So when you've got a cramp in that, you really can't move. It's very hard to walk. Very hard to have a cramp on the inside and move that leg. This one will be far worse with anything that tries to strengthen their core. So all that Pilates and planking and abdominal exercises tend to really aggravate this type of pain. It's going to be worse with prolonged sitting, prolonged standing. It's going to be sore. A vaginal ultrasound, when it pushes out towards the adnexy, people are often told you've got tender ovaries, but it's pushing on that muscle as well. And it goes down the front of the leg and often into their back and occasionally into the foot. The nerve pathways, when these get sensitised. So once you've had pain for more than 3 to 6 months, on most days, that fulfills the definition of a persistent pain condition. The abdomen's often sensitive. They'll come and say, oh, I just don't like anyone touching me. I don't like my partner's hand on my tummy. I don't like tight clothes. It's really sensitive. And that's when they start to get miserable. That's when they start to be just anxious and can't sleep, and the fatigue and often nausea and things. Sometimes there'll be burning, although that's more a vulval pain type symptom a lot of the time. So, and then there's the life impact. Pain centres in the brain are very close to the centres for emotion and things as well, and pain becomes emotional. They start to get completely miserable. There's often a fear. They don't know what the pain is. They're worried their man will leave them. They'll lose their job. They'll never have babies, even if they haven't actually got much that you can see that's wrong with their pelvis. They're often withdrawal because it's easier to stay home, and there's reduced activities, which of course aggravates the pelvic muscle pain. So, how do you get better from that dreadful everything problem? So, you've got to stop the problem that started it. You've got to reduce the muscle spasm, manage those nerve pathways, and get more back into life so your brain's got better things to think about than pain. So, looking at all the things that started it, I won't go through all of these now, but you should look at managing as well you can the actual pain that was her first pain symptoms. For women with endometriosis, it's usually period pain. And when you're managing period pain, this is what I would normally, sorry, I think some of the letters have gone off. This is what I would normally talk to people who I see that aren't necessarily looking for pregnancy about. You want to, and estrogens tend to make the lining of the uterus thicker, make periods more painful, periods heavier. Progestogens tend to make the endometrium thinner, periods lighter, periods less painful. Now, when you're trying to get pregnant, of course, the pill is not helpful, but often there'll be times, especially if you have people having fertility troubles, there'll be times, maybe between cycles of IVF, or maybe they just need to have a rest for a few months to help them get themselves well and to actually have a bit of a break from the pain before they actually are ready emotionally and physically to take on trying for pregnancy again. So I'll often see people sometimes that have come wanting to get pregnant and they've had a few cycles of IVF and it hasn't gone so well and they're just in a complete hole. And I say, why don't we just put it on hold, maybe go on the pill for a couple of months, let's help stop these periods for a little bit, and then when you're ready, you can do that again. So sometimes a break is helpful. And if you're planning a break, the contraceptive pills that are useful are ones where hopefully you can skip periods or that have very light, less painful ones. So, Levolin's one we've probably all heard of. That's the standard pill. It's not fabulous. It's all right for this sort of thing. Normin is a bit better, a bit lighter periods, and both of them, a Normin one, are on PBS. Yaz is quite good because it's a lowish estrogen one and you can often skip periods for a few months at a time. And Clara, which you might not have heard of, is a monthly pill, but it has Dinagest in it, which is what they use for endometriosis in Europe and we've just got released here, which is often really good. Clara is a great pill for anyone who says, I can't take the pill, it makes me moody. Often they're happy on this one. Skipping periods is good, so I'll often look at ways to give them a break where we could skip periods for a few months, get things back on track, then they can think about their fertility concerns. Continuous progestogen, for anyone who can't take estrogens or who doesn't like them or they're not enough. So there's the cheap old Primulet, just one daily from about day 5 of their cycle, taken continuously, will often keep a period away. Cheap and easy. There's the new Vizan, which has only been out 1 or 2 months. That's new, exciting and expensive, probably $80, $90 a month to be on, but it's what you'd get if you were in Germany, Canada or France. And the people over there think that it's got a lower side effect profile, but it's expensive, and we haven't had a lot of personal experience here. For people who are wanting to get pregnant and do get pregnant, I'd say once those periods come back after the baby, it's really good to get onto them quickly before everything goes bad again. And that's when it's time to think about a Mirena intrauterine device or something to suppress the periods. Because unfortunately for my lot, pregnancy is not the end of their troubles. Manage the stuff from pelvic organs. A low FODMAP diet is actually really helpful. You can do it even if you're trying to get pregnant. During pregnancy, it often reduces pain. I haven't got time to explain it all, but that's really good. Avoiding constipation, because that aggravates everything. And Normacol Plus is a supplement that doesn't tend to irritate irritable bowel, doesn't give them too much wind, and will often be sufficient. Bladder pain. So there's a lot of dietary triggers for bladder pain, particularly citrus. Cranberries are really bad for it. Anything with coffee or stuff like that can aggravate it, but there's different dietary triggers for bladder pain that are, once again, something they can focus on even when they're trying to get pregnant. And we have a bladder first aid for flares. So when they get a flare, rather than presume it's an infection, you can manage it often and avoid antibiotics. Vulval pain, stop using all the soaps, all the body washes. QV cream as a cleanser, just the cream they can have in pump pack in the shower is often more gentle. Dermies they could use, and a lot of people have different problems with lubricants. And the modern things in lubricants is sometimes to use a lot of the foods, so things like almond oil, coconut oil, olive oil, and are often less likely to cause some irritation for some people. Reducing the pelvic muscle spasm. Remember, anyone with just about any start to their pelvic pain can often get a pelvic muscle pain component, and it's so often missed. So, you've got to stop the aggravating factors, reduce their periods, settle the bladder, cut out the core strength stuff, but keep them moving. Every day lying on the couch is a day going backwards. Daily, gentle, regular exercise away from the core. There's some pelvic muscle stretches that anyone can look at and download at the Pelvic Pain Foundation website, pelvicpain.org.au. There's a downloadable MP3 pelvic muscle relaxation CD, another thing they can do even if trying to get pregnant, available from Patricia Newman's site at thepelvicfloorclinic.com.au. They can put it on an iPod, do it every morning on the bus or whatever, and it's got them talking and explaining how to release tension. Pelvic physiotherapy is fabulous, but there are very few women's physios who have any expertise in this area. They're great for if you've got a weak floor after having babies, but they're not good at the concept of down training. That's gradually catching on, but this is releasing tension. It's not tightening and strengthening. In my own practice for the really bad ones, the ones with the really bad stabbing pain, like the one I got rung about today who spent the last few days in hospital with unexplained pain, which fits the thing completely, we'll probably use some botulinum toxin injections on Friday to give her a few months break from the pain. Just like it's used for kids with cerebral palsy to stop spasm or to stop you frowning or a stiff neck or twitchy eyelids, it can be used for pelvic muscle pain. I've written that it's an off-label indication because it's early days with this, and I guess I see the worst. But it's really good. And I do often have people that want to get pregnant, can't have sex because their pelvic muscles floor is so spasmy. Hard to get pregnant when you can't have sex. So we might sometimes use that a month before they try to get pregnant, so they've actually got a few months of at least a better pelvic floor for that purpose. So, treat the nerve pathways. Remember, anyone with pain of any kind for more than 3 to 6 months on most days. All the things you can do. Keeping active with things that she enjoys is really important. Things with high motivational value. Things she'll do even if she doesn't feel great that day. So, it might be getting back to activities she enjoys, crafts she's enjoyed, volunteering somewhere, even if she's not working, she could be volunteering at the school if she likes children, she could be getting out. You find what she actually wants, what matters to her. Exercise, she's got to move. Regular sleep, trying if you can to manage that. Medications, amitriptyline and duloxetine are the ones that I tend to use. Of course, you wouldn't aim to be on those if she's trying to get pregnant, but once again, I would sometimes put people on amitriptyline for a couple of months. During that time, we'll be giving her a break, maybe on the pill or something, help settle her bladder, help reduce some of the pain, help improve her sleep, and then we can go off that when she's trying to get pregnant. And there's pain specialists, and please don't put them on regular opioids. It's just a trap. Getting back into life, the pain isn't dangerous. It's severe, but it's not dangerous. Keeping active so she's got better things to do with her brain than have her brain focused on the pain. Learning more about it, Pelvic Pain Foundation's got lots of information. Keeping working. Some people say, I've decided I'm going to give up work so I can focus on getting better. Usually what happens is they sit around and focus on their pain. So too much work is bad, but stopping working is bad too. And pacing activity so they don't rush into exercise and then fall in a heap the next day. But won't surgery alone be enough? Most people think, I'll just have an operation and that will fix it. Well, I've got here a bit of a video of somebody who's got some endometriosis. Oh dear, where do we go? Anyway, I've got a video of a laparoscopy showing some widespread endometriosis. Now, I think we click on this one. Anyway, she's got widespread endometriosis, you can see. Oh yeah, go to that one. Go to that one. Beautiful. And we can make it big, make it full screen. Okay, so looking down here, she's got endometriosis right across all of this area of the pelvis. So we've got clear stuff, we've got white stuff, we've got scarred stuff there. Nice ovaries, always good for having babies. And she's got little red marks, clear marks, white marks. It's all bad. That's the rectum down there, but all the stuff in front is all endometriosis. And then we've got on this side, we've got black bits, white bits. It's all bad. All of this is all bad. Okay, the whole thing. And in a minute you'll see that I've actually excised, which means cut out, all the endometriosis there. Every bit of that abnormal skin has been removed. One of the ovaries have been temporarily elevated with a dissolvable stitch to keep them out of the way while it's healing, but all of this has been taken off. So every visible bit of her endometriosis has been removed, every single bit. That will cover over within a couple of weeks, and those ovaries will return to their normal position. That's just a dissolvable loose little stitch, keeps them out of the way. So she's had every bit of her endo removed, but... Okay, so then the next one will work. Yep. So is she all better? Okay. Yep. Is she all better? No. She's got much more than endometriosis. We need to either minimise her pain, manage her constipation, manage the pelvic muscles, manage her overactive bladder, review all her mood, and I've got all these things that most of which you can do even when you're trying to get pregnant. Pelvic Pain Foundation, we actually have information for men and teens and parents and women with pelvic pain. So that's the website. Now, there's a free pelvic pain e-booklet that's downloadable, and you can download it and you can send it to anyone you choose. So there's no problem with sending it to anybody you choose. So that's an introduction to pelvic pain. We have our book, Endometriosis and Pelvic Pain. This one actually has specific management plans for every type of symptom that she might have. So that's for women and doctors or health professionals. So it's got specific plans for everything, including stuff on fertility. And I just want to say that we're doing a research project at the moment looking at young women with severe period pain and pelvic pain. And if you know anybody, or if you or anybody have women who would like to be in it, these are the criteria, and they're not allowed to have been pregnant. But anyone who goes in it will have a full, no-cost consultation and management plan made, and they get paid for coming to have 2 of their blood tests on specific days of their cycle. So we'd love to see more people with bad pain who'd love to go in our study. Thank you very much.
Okay, we might move on to our next speaker, who's Professor Ben Moll, who's from the Robinson Research Institute. He's a gynaecologist and he's a senior researcher. He's a NHMRC fellow now. He's going to talk about alternatives to fast-tracking IVF.
Who is being born after 1978? Oh, some people. So there might be some, because 1978 actually was the first IVF conception. Does anybody know, if you're born in Australia in 2015, what the probability is that you were born from IVF? Any guess? 20%? Wow, that's high. It's lower. 1 in 30, 1 in the class. That's correct.
You win the prize.
Yeah. And the prize is going to be provided by Ray. So 1 in 25, 1 in 30 children in Australia is conceived after IVF. That is lower in other countries. So, for example, in the UK and the US, that is around 1%. I have some disclosures. My institute is paid for some commercial activities I do, and I'm neither a politician nor a diplomat. And I have another disclosure, which is that I am the product of a home conception and a home delivery, 1965 in the Netherlands. So IVF is not new. It was first thought of actually already in 1937, before all the technology was available, by John Rock, who formulated the principle in the New England Journal of Medicine. And then it were Edwards and Steptoe, Edwards the scientist and Steptoe the gynecologist, who started to experiment and actually try to put it into practice. And it was 1969, the year that men first put foot on the moon, that also the first in vitro fertilization was there. And after having established that, they started really to treat women, and the first actually in vitro conception resulting in a pregnancy was an ectopic pregnancy, published in 1976. And then in 1978, Louisa Brown was born. It was actually the first baby conceived after IVF. And here she is with her own family and her own baby. Now realize that the indication actually for the treatment of the mother of Louise Brown was the fact that she had lost her tubes. So there was no possibility whatsoever that the mother of Louise Brown could have conceived the other way, because prior to the IVF procedure in August 77, she had undergone an excision of both tubes. So she was actually sterile. And it's important to realize that actually since then there have been no comparative studies that show in whom IVF is effective and whom not. And there's a very good editorial by, or a piece of work by Paul Glacio from the Gold Coast in BMJ that actually explains that sometimes we need comparative research and sometimes not. Because he says that if noise, let's say the natural course of a disease, or in our case natural conception occurs, and a treatment really makes a difference, then you don't need further comparative studies. So to put it into IVF, if you had the mother of Louise Brown, who didn't have any fallopian tubes anymore, she couldn't conceive naturally. So the noise was actually zero. And then when the treatment worked, that was obviously proof that that treatment was effective. But if we do the same in a couple where actually we cannot find any cause for the fact that they don't get pregnant, how do we actually know that IVF adds anything? And we actually don't know that for sure. So the focus of the talk is that for some women, tubal obstruction, severe male infertility, low semen, or ovulation induction, where we are unsuccessful in getting an ovulation, actually where the gametes, the sperm and the egg, cannot reach each other, their IVF is effective. And we also know from randomized study, a very small one, that if couples try to conceive for more than 3 years, IVF for certain makes their prognosis better. But in other couples, and that's, I think, more than half of the couples actually that undergo IVF, we don't actually know whether IVF is better than the alternatives. So we should consider, I think, before IVF is started, who really needs the treatment. After having the 3 talks before, and what you know about it, who thinks that IVF is completely safe? Nobody. Who can inform us on the risks. What risks are there? Sorry? Multiples, but that's controlled in Australia by single embryo transfer. But actually all the issues that Claire talked about, preterm birth, growth restriction, they occur a little bit more in women conceiving after IVF, even in case of single embryo transfer. And then there is potentially another concern, which is the later risk in life. And Rebecca Robker has informed you about what happens to the embryo at the first stage of life. Well, actually, we are not that sure that being in a test tube the first 3 days in your life is that safe. You're laughing? So if we look at, this is a Dutch study, looking at couples who enter a fertility clinic, then we see in the black curve that after 3 years, 70% is pregnant. But natural conception actually contributes quite a lot to that. So IVF, ovulation induction and IUI also do. But if we then look specifically at the group of unexplained infertility, where we actually can't find a cause, then the overall prognosis is good. 80% of those couples gets a child after 3 years, but 3 out of 4 get it actually through natural or so-called home conception. So the question is, are we overusing IVF? Also in view of the limited resources we have in healthcare and the choices we have to make. So alternatives for IVF. Maybe delay treatment for a while. Are there alternative treatments? And the final question, when actually should we stop with IVF? After 3, 4, 5, 6 cycles, how long should couples conceive? So first, natural conception. Remarkably little research on that, but this is a good study from Germany that actually followed about 400 first pregnancy planners and looked at the time of conception. And what you can see that after, this is about 2 years, 95% is pregnant and 80% reaches that pregnancy within 6 months. And then in the next 6 months, there gets another 10% pregnant, adding up to 90%. This statistics means that if you are not pregnant after 6 months, you have a 50% chance that you conceive naturally in the next 12 months, which is actually, I think, a pretty good statistic. And we can also help couples here by calculating prognosis. I was involved in several of the studies, and this is a prediction model we developed where we actually looked at factors like female age, duration of infertility, and some findings of the workup. And it's then a score that you can calculate, and the higher the score, the worse your prognosis is. So you can put that in a chart where actually the higher, and the bar fell away here, but the higher your score is, the lower your prognosis gets. And this allows us actually to identify and inform couples who can start with treatment, those with a poor prognosis, and couples who might be wait a while. So we did a study on that, and we actually asked couples with a good prognosis whether they were prepared to wait for another 6 months or start treatment with IUI with hyperstimulation, so no IVF. And after 6 months, we were actually surprised to find that those couples who, in blue, were sent home had higher pregnancy rates than those who came each month to the hospital for IUI with hyperstimulation. Interesting thing. And after 3 years, there was no difference whatsoever. So it was one group that had waited 6 months at home, the other group started immediate treatment. It does not affect the pregnancy rates after 3 years. And then lifestyle treatments, obviously. This is me going to the gym. Works quite well. Because that's often said, if you're unhealthy, your fertility prognosis is affected by the fact that you have a high BMI, should we invest in lifestyle studies? I was also involved in a comparative study where we again randomized women, in this case women who were obese, so a BMI of 30 or higher, for first a lifestyle intervention or immediate treatment. And the outcome was that the women who followed the lifestyle programs had after 2 years 50% ongoing pregnancy rates, and this was 58% after immediate fertility treatment. So actually a slight advantage for the immediate fertility treatment. And if you look at the total number of pregnancies, the ongoing pregnancies, then there was actually very limited difference between the two. And plotted in a curve, this is time to live birth, so the first baby born. So everybody in the study, obviously not pregnant before the study, takes 9 months to get the first babies born. And then there is a slight advantage of the group who gets immediate fertility treatment. So not necessarily an improvement of lifestyle increases the pregnancy outcomes. I think that we should advise couples to improve their lifestyle, but if they don't succeed in that, I don't think that should be a reason to withhold treatment in the end. And then potentially other treatments for IVF. I touched already upon intrauterine insemination. After having done the study where we compared in good prognosis patients for IUI and no treatment, we wanted to do the same in people with a poor prognosis. But actually it's very difficult to randomize there, because if you have tried to conceive for 2 years, then you're not going to consent in 50% chance of another period of waiting. So what we did is we didn't randomize, but we looked for couples who started a treatment and then dropped that after 1 or 2 cycles and just had the chance of natural conception. And we compared them to immediate treatment. And again, so this is poor prognosis couples. IUI doesn't add anything over expectant management. And only when we added the IVF pregnancies, there was a difference between treatment and no treatment. So I think that the proof that IVF or IUI actually is working is very limited. But the good thing of IUI is it keeps you for a while out of IVF. One other study, we also compared IVF with single embryo transfer with IUI. And in this study that was recently published in BMJ, we didn't after 12 months find no difference whatsoever for prognosis patients, and realized that I previously showed that IUI doesn't show anything over no treatment, and IVF, the single embryo transfer, doesn't in this study add very limited to IUI. So again, I think we should be careful with early treatment. And then another category of women who don't ovulate and actually need ovulation induction. I think it's very important to invest in getting them ovulated, because then usually their prognosis is quite good. This is the long-term outcome of a study where women were treated with gonadotropins, which makes you ovulate for 1 cycle, as to compare to so-called laparoscopic drilling, that results in a restorage of the cycle. And if you compare those treatments for getting a first child, there is no difference. But, and realize this is a randomized study, if you look at the second child, then there are in the drilling group much more women who get a second child. And they were, due to randomization, similar at baseline. And the explanation for this is that women who get the drilling had a restorage of their normal ovulation and could get pregnant without further medical help. So apparently they want 2 children, or even 3, as this study showed. But if they have to go back to the hospital, that they are less likely to do that. And then finally, how long do we continue IVF? And as expressed by this slide, we have difficulty actually in spelling that word. Stop. When to stop. So there have also been studies done actually calculating what the expectancy is of a next pregnancy after a failed IVF cycle, which is quite important. So that's summarized in this paper that actually looks at a large cohort of couples, but they're not so much prognosis for the first cycle, but tries to predict what happens thereafter. And what you can see, and this is the development set And this is the validation set. So this is actually the set where the model is tested in another population. You can see that we can identify actually quite accurate couples that have a less than 10% chance to conceive with IVF. And I think this should be used really to counsel couples after 1, 2, 3 cycles to help them decide to go on with IVF or not. And here is that in several patients demonstrated, so you can look at duration of infertility, different age categories, but also quality of the embryos at the initial cycles to see what their expectancy is. And then some people have 25% chance, but others only have 5% chance. To summarize, there are alternatives for IVF. I didn't touch upon that, but I think I should call it at this stage. It's also very important that we explore more the sexual relation in couples. We don't do that a lot. There's usually a kind of routine question, and then both the man and the woman answer that they have sex 2 times a week, and then you hope that that is together. Yes, you're laughing, and you're laughing because it's taboo. We don't ask it. I sometimes got the impression that people see each other for the first time when they're with the doctor actually as a couple, because they just don't have that relationship, and we don't ask it. And actually, if we have that, and there would be a sexual problem, then a very simple insemination would help that couple really a lot. So I think we should inform couples on natural prognosis. There are treatment alternatives, and lifestyle interventions play a role. And in the end, IVF will help a lot of couples that will not conceive in other measures. So therefore, we should not wait too long. And this is obviously a good reason to come to Australia. We can't take that pictures in the Netherlands. And then my final slides. I started with my announcement of my birth. This is actually the announcement of the marriage of my parents. My mother was born on November the 6th, 1932. So I was actually conceived somewhere early in 1932. I was born in 56, but my parents I was born in 65, but my parents married in 56. And I am the oldest son. So it took them actually 9 years to get me. And the irony is that when there would be IVF in my area that I was conceived, I probably would have not be there, because my mother would have IVF earlier. And it's also interesting to realize that actually the gynecologist that my mother was seeing said to her at a hysterosalpingography, a picture of her tubes, "Oh, Mrs. Moll, your tubes are closed," he said in 1964. "You should have told me that immediately." It's still a trauma for her. Realize also that I was involved in a study comparing HSG with water and oil, and we just have the results. It's not here because it's going to be presented at ASHRI. And oil gives you, over a period of 6 times, a 10% higher pregnancy rate than water in the expectant period. And the big question we should ask ourselves, why actually do we know that only in 2015, whereas this should already be known in 1965. The final slide. Medicine in 2015, or think of it what you want. Thank you.